immediate outcome following valve surgery for rheumatic heart disease, the first local experience from Ethiopia. Dr. Agwar?
Yes, thank you very much for inviting me and giving us the chance. So, as you know, Ethiopia is one of the most resource-limited country in the world, and it's one of the sub-Saharan African countries. And we are among those countries to implement open heart surgery very recently. So I'm again glad that you have given us this chance to experience our open heart surgery. Specifically, we are reporting the first 117 rheumatic heart disease surgeries that we have performed, and this paper is published in the Journal of Young in the Cambridge University Press. So once again, thank you very much, and I will share my slides. Can you see my slides? Hello? Can you see my slides?
Yeah, doctor, we can see your slides. You can go ahead.
Yes. So, as you see, this is the operative mortality of 117 rheumatic heart disease patients who have been operated by the local team, the first complete local heart team. As I have told you, our country, Ethiopia, in Addis Ababa, there is a cardiac center of Ethiopia, which is a charity organization, a charity heart center where people have this open heart surgery for free. And this hospital used to do cardiac surgery by the missionaries who are coming from all over the world by a fly-in missionaries, and they will stay for 5 to 10 days and they will go back to their country. But as of 2017, the local team who has been trained from elsewhere in the world has come back to the country and launched its first kind open heart surgery by the local team, by the complete local team. So, as you see, this is a local heart team, me as the surgeon and the assistant surgeon, and the one that you see, the hospital where the cardiac surgery have been started in our country with the local team. As you know, this rheumatic heart disease is one of the most common diseases in developing countries, and we are going to tell you about the immediate outcome of the local team with a complete local team of the first of its kind. As you know, surgery for rheumatic heart disease has evolved tremendously in the past 70 to 80 years, and nowadays there is a saying that up to 70% of rheumatic mitral valve disease can be repaired with a good outcome. Of course, the decision to repair, especially rheumatic mitral valve, is heavily put on the experience of the surgeon. But the most important thing, apart from this, is how much the valve is damaged. Especially the subvalvular apparatus thickening and calcification is the most important parameter to decide whether to repair or to replace a valve. As you know, the operative mortality of mitral valve repair is 0.7%, but this is when we talk about for all the etiologies of mitral valve regurgitation. But when it comes to rheumatic heart disease, repair mortality can be as high as 4.2%. And mainly this is because of there might be going back to bypass and cross-clamping that again because of failure of the failure of repair technique, and you have to go back again and again. And because of this, the operative mortality might be very high. Apart from this, this rheumatic heart disease can affect multiple valves, and the operative outcome becomes even worse when this RHD affects multiple valves. especially in our setup, there is a chance that you might have a patient with multiple valve involvement because most patients come with an advanced stage of the disease, and most of them are a neglected situation. So as we have started, this study was conducted at 2 centers, mainly at the Cardiac Center of Ethiopia, where we have done most of our cardiac surgery, and we have started at the cardiac surgery at the Cardiac Center of Ethiopia. This Cardiac Center of Ethiopia is a charity hospital where cardiac surgery is delivered for free. The other hospital is El-Ouzier Cardiac Center, which is a cardiac hospital only, where the hospital run by foreign investors, but the local team fully operate at the hospital also. So all these patients were diagnosed to have rheumatic valvular heart disease and who underwent open heart surgery by the same local team at these 2 hospitals are part of this study. The diagnosis of this rheumatic heart disease was done by the World Heart Confederation criteria and the American College of Cardiology and the AHA definition criteria. And their pulmonary artery hypertension was graded according to mild, moderate, and severe, and those patients who have pH of more than 65 are said to be severe pH. The protocol of our center is to operate only to those patients who are symptomatic and who have severe form of lesion, like severe MR or severe MS. Of course, in our center, almost all patients have severe form of the disease, and it is unlikely that you will have the chance to see patients who have surgery who have a moderate form of the disease. So the data was abstracted from the patient files by using a structured questionnaire. And the surgical technique protocol we use was a standard midline approach with ascending aorta cannulation and 2-stage single atrial cannulation if the surgery is done for only aortic valve. But if surgery involves mitral valve and tricuspid valve, or if it's only mitral valve, we have to cannulate by caval cannulation. And for all the rest of the surgeries, that will be the same as bicaval cannulation as mitral. Our cooling technique is almost always to 32 degrees centigrade, and St. Thomas cold blood cardioplegia is delivered through the aortic route. If aortic surgery is there, then we have to open the aorta and we have to deliver the cardioplegia directly through the ostia. Mitral valve surgeries are approached all through the L-layer by using a Sondergaard line groove, and aortic valve surgeries were approached using a J incision into the non-coronary cusp of the aortic valve. And all tricuspid valve surgeries were done by an incision which is parallel to the AV groove, and all tricuspid valve surgeries were done on a beating heart, which means if we have to do a triple valve, mitral, aortic, tricuspid, we will finish both valves and then we'll release the cross clamp and we'll do the tricuspid valve repair on a beating heart. As you see, this is a classic mitral valve exposure by using the Lewis-Francis mitral valve exposure for pediatric patients and the local team operating. Those patients, especially who are young ladies who want to have a safe pregnancy period and who don't want to have a mechanical valve, will be given the chance of choice to have tissue valve. And sometimes we do also a mitral valve repair for those patients who are very young and for females who are very young patients. And the mitral valve repair techniques we were using were mitral valve annuloplasty ring by augmenting the posterior mitral valve leaflets and by doing chordal and papillary muscle mobilization. Tricuspid valve repair was done almost for all by using autologous pericardial remodeling annuloplasty ring. This is because we are a country where we have a lot of resource limitation, and we may not get rings for all patients, and we may not get the appropriate ring size for each patient. So what we have adapted is we will use only an autologous pericardial remodeling ring, which will be available for all patients, and almost more than 85% of our patients are with tricuspid valve repair will have his own autologous pericardial ring, but sometimes when we have the MC3 ring, we will use this MC3 ring. The left modified maze procedure was done for 2 patients in our patients who have chronic atrial fibrillation and giant left atrium. Both of them have 70 and 75 millimeters. The technique used was based on the original cut-and-sew technique of the maze procedure, and our left maze procedure that we have performed has a component of isolating the 4 pulmonary veins, left atrial appendage excision, and left atrium reduction. Cut-and-sew technique line connecting the mitral valve and annulus were the technique that we have used. We have 3 redo surgeries in these 117 patients, and all the redo surgeries were entered via the previous midline incision, and cannulations were central. The indication for the redo surgeries were previous tissue valve, which undergone severe degenerative calcification and subsequently developed high gradient. The other patient was developed stuck valve. That was a mechanical valve with an 32 years old, and we have to do a redo surgery. The follow-up in the statistical analysis were the occurrence of any major complication, mainly days, reoperation, stroke, and complete heart block in 13 days of the operations. Data were analyzed using the statistical package for social science version of 20 for window was used. When we come to the results of all the 140 patients, the median age was 31 years. As you know, this 31 years is very high age for rheumatic heart disease, and the highest age was 75 years and the youngest was 9 years old. And as you see from this data, most of our patients are in the age group of 16 to 30 with 38.6% of them, and 60.7% of them of our rheumatic heart disease patients are more than 45 years old. About 72% of our rheumatic heart disease who undergo this surgery have class 3 and class 4 NIHA heart failure symptoms, and about 67.5% of the patients have moderate or severe pulmonary hypertension. And 55.3% of our 114 patients have atrial fibrillation, be it fine grain or coarse grain. And 10 patients have some form of comorbid illness before the surgery. So this is what we have talked so far, the class 2, the class 3, the class 4 patients share. And the atrial fibrillation share is 55.3%. And as you see, the body mass index, most of our patients lies in from 80.5 to 24.9 body mass index. The majority of them are below 24.99. So when you see the type of surgery that was performed for these 114 patients, as you see, almost more than 90 patients have mitral valve replacements. Few patients have mitral valve repair, and 3 patients have a redo mitral valve replacements. And of all the mitral valve replacements, about 83 were mechanical, and only 5 patients have received tissue valve replacement. As you see, 9 patients have double valve replacement purely, and 2 patients have aortic valve replacement with mitral valve repair, and 5 patients have aortic valve replacement plus open mitral valvotomy, and 9 patients have double valve replacement with tricuspid valve repair. So, as you see, 90.4% of our study has mitral valve surgery, be it isolated or in combination with the other surgeries, the other valves. And of these 88 patients, 83 had mechanical and 5 had tissue valves. 36 patients have aortic valve surgery. And as you have seen, open mitral valvotomy was done for 5 patients. And all the 5 patients who have open mitral valvotomy, we are having aortic valve replacement surgery. Postoperatively, the mean gradient across the mitral valve for all the patients who underwent mitral valve surgery was below 5 millimeters of mercury, and the mean in the peak post-op aortic valve gradient was less than 20 and 30 respectively. 3 patients have a previous history of cardiac surgery for rheumatic heart disease, and all of the 3 were 5 years and 10 years before this second surgery. 1 patient had a previous percutaneous balloon mitral valve commissurotomy that was done 5 years back. So, as you see, most of our patients will undergo mitral valve replacement, and this is just a sample of our patients who underwent such kind of surgery. They will have mitral valve replacement, and their gradient is almost most of the time less than 5, with gradient of 3.29. So, as I have told you, all the 3 patients who have received a redo mechanical valve replacement surgery, the valvotomy patient who underwent surgical repair of the same valve, and aortic valve replacement. As you see, this is one of the patients who have tissue valve replacement 5 years ago, and this time around the valve was degenerated and calcified and stenosed, and the gradient was very high. So this was the valve which was explanted, and it was replaced by mechanical valve. When we come to the operative result, the median bypass and cross-clamp time was 110 minutes and 69.5 minutes respectively. And the left maze procedure surgical treatment for atrial fibrillation was done on 2 patients, and it was successful only on 1 of the patients. With the second patient, the surgery was not successful. So the successful patient who underwent left maze procedure, as you can see in this please excuse me for the quality of chest X-ray before the surgery. As you see, the cardiomegaly was very huge, and after the surgery, you can see the tissue valve which he had, and as you can see, the LA reduction has reduced the cardiomegaly tremendously, and post-operatively, the patient was in a complete sinus rhythm, and as you can see, the size of the left atrium is 40 millimeters. As I have told you, preoperatively, the size of the LA was 75 millimeter, and post-procedure it was 40 millimeter. Apart from being sinus rhythm, this patient has also AE ratio, which shows about 2.6, and which means that she has a good atrial transport function. So post-operative result, almost half, or 47.4% of our patients had required mechanical ventilation for less than 6 hours, and only 8 patients were ventilated for more than 12 hours. This is the hours for our post-op patients with their numbers, with their respective numbers. So when we come to the patient outcome, of the total 140 patients, 5 patients, or 4.4% of our patients has died within 30 days of the following the index surgery. 19 patients, or 60.7 patients, has developed at least one form of post-operative complications. 8 patients developed cardiac tamponade due to this massive pericardial effusion. All of them underwent subxiphoid surgical drainage was done for all of them. 4 patients had bleeding, and they have required re-exploration following their surgery within the first 6 hours of the surgery. 2 patients developed 30-degree complete block, and only one of the patients became symptomatic and had permanent pacemaker implantation. Another 2 patients had a stroke post-operatively, and one of them has died because of this massive stroke. Additional 2 patients developed surgical site infection, and both of them required exploration of the wound. One more patient who was a case of mitral valve disease. She's a 9-year-old female patient. She underwent valve repair, and after she was transferred to the ICU, the echocardiography has shown she has severe mitral valve repair, severe mitral valve regurgitation. So we have to take her back again. After the 5th postoperative day, we have to go back again, and we have to re-repair the valve, and this time the operation was perfect. So as you see, 5 patients, right? So this is the first valve surgery being done by the local heart team. This is a historic picture of our country where the first valve surgery was being done by the local team. So the current series, only 30.2% of the patient underwent mitral valve repair. So why is that? We know that our patients are, these rheumatic patients are young. Why are not they undergoing more repair is the question. So the most plausible reason is that this is the early phase of launching open heart surgery. As you know, valve repair, especially mitral valve repair, needs a lot of experience. And because of that, during our early phases, the number of patients who are undergoing valve repair was minimal. But as time goes by, this number has increased tremendously. The other factor for our less number of valve repair is the mean age of this study is 31, as you have seen it from the result, which makes it the natural history of rheumatic heart disease unfavorable for repair, because by this age, most of them have a mixed lesion, regurgitation with stenosis, which makes it unfavorable or short duration or a non-long-lasting repair outcome will be there. The other important factor is in a limited resource setting like ours, cardiac surgery is always a lifetime, once lifetime chance. So nobody will have a second redo surgery. So having this in mind, we tend to always go for valve replacement than repair if things are favorable for the patient. So I want to show you one of the valve repairs that I have talked in the result section. This 9-year-old patient presented with severe MR. As you see, the MR is very severe, and because of that, you can see that the left atrium is giant. Almost all of our patients are like this, very giant LA, huge cardiomegaly, presented with recurrent heart failure, recurrent admission to hospital, and most of them come with near class 4. So this was our first repair. We do a repair with a technique that we use. That means we do annuloplasty ring, we do the papillary muscle and chordal mobilization, and we do secondary chordae release. So this was the outcome. As you see from this echo, there is still severe MR, which is eccentric jet, which is directing to the AML. So this was without color. So we have to go back again, and we have to do this kid again. This means 5 days after the first surgery, we have again taken this patient back. And because she's 9 years old and because she's a female, we don't want to replace this valve. So we have repaired it, and this was without color outcome. As you see, the coaptation is very good. The coaptation height is more than 8 millimeters. So this time around, there is no MR. So we were very happy with the outcome, and patient is doing very nice. Post-cardiotomy syndrome, as I have told you, we have a lot of patients in our study, there was about 7% of our patients has developed tamponade. This is significant. We attributed this significant amount of cardiac tamponade because all of these cases has occurred in valve replacement surgery patients, which means they are taking oral anticoagulant. And the other is we attributed that most of these patients who develop tamponade are having a chest tube drainage, significant amount of chest tube drainage until the chest tube is being removed. And we initiated aspirin in this patient despite all this significant drainage and despite having a low platelet count. And the NSAID and the steroid have not been initiated in an appropriate time to decrease the chance of significant tamponade physiology. So because of this, we attributed that this post-cardiotomy syndrome has occurred in 8 patients have undergone subxiphoid drainage. But subsequently, we we have improved all in these areas, and the number of patients who are undergoing subsequent drainage has almost significantly dropped. 4 patients have underwent re-exploration because of bleeding postoperatively of these 140 patients. And as I've told you, this redo surgery is only 3 patients. It's not a significant number. We cannot make a conclusion out of this, but we are very glad that in our initiation time, we have done this, all these three redo surgeries are ended up nicely without any complications. The other important part of our surgery is the left maze for chronic atrial fibrillation. As you know that left maze procedure is an effective method to treat atrial fibrillation surgically, especially in those undergoing concomitant mitral valve surgeries. And the local cardiac surgical team didn't do the procedure liberally for more patients for different reasons. The most important reason being because of the long cross-clamp time. Patients has to stay a long time in the ICU, and in a resource-limited situation, that may consume the most important resource, which can be shared by many patients. And there is a difficulty to attain hemostasis, and that by itself will consume a lot of consumables, and patients might have a very bad post-op status. And we have a lack of alternative energy sources like cryoablation and so on and so on. And because of this, we are only doing the cut and sew technique. So because of these main reasons, we didn't do enough amount of this left maze procedure, despite there are a lot of eligible patients who needs this left maze procedures. No patients underwent tricuspid valve replacement in our setup. As I have mentioned it in the result part, 5 patients had rheumatic tricuspid valve stenosis who underwent triple valve surgery with double valve replacement and tricuspid valve repair. We chose tricuspid valve repair than replacement because of the morbidity and the mortality associated with triple valve replacement. In conclusion, the local team has excellent immediate patient outcome following open heart surgery done by the local cardiac surgical team for rheumatic valvular heart disease in a resource-limited setting. The experience reported in this article will serve as a lesson to build surgical capacity in a resource-limited setting where the disease is most prevalent. Thank you.
Thank you very much, Dr. Agwar, for your most interesting presentation. I'm sure all of us attending can't even imagine the difficulties you had to go through to manage so many excellent surgeries. I'd like to now open the floor up to conversation and questions with Dr. Agwar. Any comments?
Yes, please, Dr. Edward, how are you?
I'm fine, how are you?
Yeah, this is a very nice presentation about valve surgery and including repair and replacement. My question about in patients with mitral valve replacement and atrial fibrillation, are you performing maze operation for all the patients or in selected patients? And the second question, what about the recurrence rate of atrial fibrillation after maze procedure?
Yeah. Thank you very much. In our method part, we have clearly depicted that we given the chance of left maze procedure only for those patients who wanted and who requested it, especially for young females who don't want to have a complicated reproductive age, or who want to have a safe pregnancy. So those 2 females, they chose to have a tissue valve replacement with maze procedure, left maze procedure, because they don't want to take warfarin and they want to have a safe pregnancy. And based on the request, because these patients have, as I have told you, have an advanced disease, severe MR, severe MS, and huge giant left atrium with coarse type of atrial fibrillation. So for this patient, based on the options that we have given them, they preferred to have a tissue valve replacement with left maze procedure. And if the left maze procedure is successful and they are converted to sinus rhythm, that means warfarin will be only given like 6 months to up to 1 year until the tissue valve is well epithelialized with the natural, her own cells. Then after that, warfarin will be discontinued and she will have a safe pregnancy. So based on this premise, we did two same procedures, tissue valve, mitral valve replacement, and the left maze procedure with those components that I have mentioned: LA reduction, atrial appendage excision, and all the pulmonary valve isolation catenacy technique. For one patient, it was a complete success with complete sinus conversion. For the other patient, there was no conversion rate to sinus. So the rate of success in our situation is only 50%, but we cannot generalize for two patients. If you ask me, the original catenacy technique success rate, it is 90 to 94% success rate of conversion to sinus rate by the original, not the ablation and the new energy ablation technique. I'm talking about the original catenacy technique, which has a complete, you know, that it can cross the whole layer, so there is no chance of this electrical, this abnormal electrical rhythm to go into the conduction system. But for this new energy systems, the success rate of left maze procedure is not more than 65%. The maximum is 65%. But the original catenacy is 90 to 94% success rate of conversion to sinus rhythm. And our two surgeries, which were performed for two young ladies, is 50% success rate.
Thank you so much.
May I say something? Thank you very much for the presentation. The problem with rheumatic mitral valve disease is a little bit different when we are comparing group of patients with rheumatic versus non-rheumatic. And we can consider, or maybe we should consider, that the MACE procedure could be not that successful, because this kind of patients with rheumatic valve disease, they do have fibrosis into the left atrium. So this is why sometimes the procedure is not successful. And maybe my question is, are you doing, or did you try to do LAA closure surgically at the time of the operation? Maybe this, it will be a good idea for those that continue to have atrial fibrillation and they are trying to stop the anticoagulation in some point. Thank you.
In this, thank you very much. It was a nice question. In those maze procedure, we didn't close the appendage. We excised it out. Not closure. So in the left maze procedure, the components are appendage excision, the four pulmonary vein isolation, and LA reduction. All these together, as you have seen, it has decreased the cardiomegaly that you have seen on the chest X-ray tremendously, because there is a lot of chunk of tissue being taken out during LA reduction, and during your excessive suture technique, there are a lot of layer of the LA will be reduced. That's why she has a lot of reduction in the cardiomegaly to that normal size heart. So in our left maze procedure, we do excision of the appendage, but in the other patients where we are not doing left maze, most of the time, for those patients who have a lot of clots in the LA, we have a tendency of closing the LA appendage by using fluoroproline in 2 layers. Thank you.
Thank you again, Dr. Agwar. If there are no further questions, then